So, hello and good evening, everyone. Welcome to the 131st Blades virtual seminar. Sorry for the inconvenience for today. And start with Blades virtual seminar is a platform that allows healthcare professionals to discuss current management updates of different health-related topics for better patient care. And today's virtual seminar is brought to you by bluehealthethiopia, a medical consultancy company founded by medical doctors and a computer engineer. And we aim to be an influential healthcare leader in creating a skilled community through easily accessible knowledge and preventive medicine. And I'm your host, Dr. Heno Tadala from Blue Health Ethiopia. Today it's a pleasure to have Dr. Selam Bogale here with us to have a presentation on Marburg virus disease, the ABC focus on case management. You might remember Dr. Selam from his previous presentation on HIV/AIDS in Ethiopia 2025. So Dr. Selam is an internist and infectious disease fellow at Addis Ababa University with clinical teaching and research experience in infectious disease and antimicrobial resistance and digital health. He earned his Doctor of Medicine degree from Juma University in 2011 and specialized in internal medicine from Addis Ababa University in 2021. And he began his fellowship training in infectious disease in 2024. Dr. Salam, the stage is all yours.
Thank you so much. I'm audible, right?
Yes, you're audible.
Thank you, Blue Health, and thank you all of you who take time to have the session with us. And today, usually the sessions of Blue Health are on Thursdays today. So it is a pleasure to have about Marburg disease because it is an issue currently. So we'll share briefly about Marburg virus disease. Sorry, I will try to finish by 8 in 40 minutes. I will try to finish in 40 minutes so that we'll have time for Q&A. So these are the contents of my presentation. We'll have a very brief overview of the virology, epidemiology, transmission, pathogenesis, clinical picture, and we'll see how they recently managed in Rwanda and how they succeeded in reducing the mortality from the usual 80 to 90% to 23%, which is amazing for an African country. So we'll share their published experience as well as the experience they shared us via different platforms. So it is a pleasure to have you. So this is going to be how we are going to proceed now. So viral, when we start a virus, usually we start with classifying the virus. So this is an RNA virus. Viruses are classified as either RNA or DNA virus, and this is an RNA virus, and it is an enveloped virus. It is good to know this one because I'll come to it in a little bit. And in this family, it is a Filoviridae. So in this family, it has a cousin with a close genetic similarity, but not identical, but some overlap clinically, almost indistinguishable from Ebola. So Filoviridae are the most important pathogens when it comes to viral hemorrhagic fever. So እዚህ ጋር እንግዲህ RNA virus መሆኑ it has some advantage. I mean enveloped መሆኑ because when a virus is enveloped, it is usually easier to eradicate, especially like from surfaces and inanimate objects, okay? Because you can just eradicate it with like bleach or detergents and like that because it is enveloped. Enveloped viruses are easy to eradicate this way. So it is a negative sense RNA virus. So translation will occur after, not directly, and it has various viral proteins, including the ones that you see here on the outer part. Inside, you will see the RNA. This is a single-stranded negative sense RNA, and it has outer layers, as you can see, and the most outer part is the one that they named it as just the glycoprotein ማለት ነው. So this is the one that is important for the attachment of the virus into the host cells. Additionally, there are this is important because one of the therapeutic targets for the monoclonal antibody is this glycoprotein. Additionally, it has different viral proteins that are named by different numbers. So P35 and P24 are important pathogenesis wise. So just to know this basics of virology otherwise for clinicians, just knowing this, I guess would be enough once more. So if we see the epidemiology and the initial outbreak, the first reported, this is from CDC, the first case was identified in Germany among scientists who work in a laboratory. So they take animals from Central Africa and they were experimenting in the lab, doing experiments in the lab, and it was first reported among those people who had contact with this monkeys ማለት ነው. So they took monkeys. Primates can also be infected by Marburg, and so this is how it was first identified. And Marburg is a city in Germany, so it is after this city that this virus is named. Now, as you know, we don't name viruses after cities, okay, or countries because of the possible stigmas, but this was in the 1967 before the WHO's rule. As you can see here, the rest of the outbreaks mostly occur in the central parts of Africa. So like in countries like South Sudan, our neighbor Kenya also, Tanzania, Rwanda, Botswana, all this like our, not Botswana, Guinea, Angola as well, Democratic Republic of Congo, as you can see here. There are also cases from South Africa, but the central part of Africa is an area where we have seen repeated episodes of the outbreak starting from the first report in 1967. So to see few of the most important outbreaks that occurred until the recent 2024 in Rwanda, we do have outbreaks in Congo, in Guinea, Angola, South Africa. The initial, as I have said, was in Germany, Uganda, Kenya, had also different outbreaks at different times, and Tanzania also had an outbreak in 2030 and in 2023. And in September of last year, as you know, in Kigali, in Rwanda, Kigali, there was an outbreak. We will review how that unfolded because it gave us a very solid understanding on how to manage relative to the olden days ማለት ነው. Okay, this is important. The other thing maybe that I want to stress from this picture is, as you can see, in the outbreaks, the maximum that you can see እዚህ ጋር ስንት ነው? It is 200, like 252 cases, 252 cases, okay? This is not transmitted by airborne, and asymptomatic individuals do not transmit it. So outbreaks involving like thousands and tens of thousands and millions of people is unlikely ማለት ነው. Not even thousands of cases ራሱ has not been reported, as you can see here ማለት ነው. So እንግዲህ ያው God knows what is going to happen tomorrow, but as you can, but if you want to guess from this history of the outbreak, more likely the maximum that we might have would be a couple of hundred cases and deaths ማለት ነው. So it's not like COVID or influenza or some other Yersinia or other disease that cause a lot of deaths and become a global pandemic ማለት ነው. So this is important. So transmission wise እንግዲህ when we come to the transmission, I'm audible አይደል? The coordinators ዶክተር ያለው audible ነው? ስክሪን ይታያል? Is the
Yes,
screen
sir.
visible?
Yes, you're audible, doctor. You can
Okay,
continue.
text me directly, text me if there is any
Yes,
issue.
audible.
Mm.
ይታያል በደንብ።
Yeah, as you can see,
Yes.
so
እሺ።
the bats are the ones that are reservoir and Okay,
All right.
the bats are uh, sorry. Okay, thank you. So the bats are usually the ones that will harbor the virus, but they themselves will not usually get uh, ill or die from it. Okay, so usually people who are in close proximity to bats, for example, those who work in countrysides, in forests, in caves, especially in caves and in rural areas, they may get closer to the like urine, feces, or dead bodies of these bats, and people might get it via that way ማለት ነው. After that, human to human transmission is via contact. So the first case usually is from bats, or sometimes just like us in Ebola, humans can also acquire it from primates ማለት ነው. So this is the main route. So you don't see like mosquitoes or lice or any other vector causing the disease ማለት ነው. And human to human transmission afterwards occur, as you can see, via contact. So there is no aerosolization in the community for community transmission ማለት ነው. And the other important thing that I want to stress is patients who do transmit are usually the ones who are symptomatic. You don't see asymptomatic transmission like as in the case of in COVID. Okay, so asymptomatic transmission doesn't occur in this case. So it is only symptomatic people who do have this disease, and most of those who get the virus will actually be symptomatics. The other thing is, in some of the patients who recover, the virus might remain for a while in certain body fluids. For example, in males, in the semen, it can stay for a while. So those who have recovered are advised to use protection for at least 12 months by the WHO. Actually, this is from a case initially in one of the outbreaks in the late 60s, where a husband transmitted the virus to his wife, possibly via this route after recovery. Okay, so this is another issue that I want to stress. So previously I've said that the most important mode of transmission is contact. So let's define contact. So it has to be with any body fluid directly or indirectly ማለት ነው. So for example, sleeping in the, or living in the same household, direct physical contact with a live ill patient or a dead body. Sometimes people, like after someone died, there are different rituals in different traditions. People wash the dead bodies before they bury them አይደል? Or put them in the caskets. No? Such such handling of a dead body usually transmits the virus a lot. The other thing is funerals also are important sources indirectly as well. And touching any fluid from the patient, it could be vomitus, blood, or any other fluid from the patient is highly contagious ማለት ነው. This includes also needle prick injury in healthcare setting. The other thing is some inanimate objects like clothes, linen, like bed sheets, blankets and like that, that are soaked with fluids that come, that's from a patient. It could be vomitus, diarrhea, or any blood could potentially does transmit the virus. There is also transmission from mother to child, transplacentally, as well as during breast feeding. The other important thing is, as I've said previously, sexual contact is also important. The other thing is in the healthcare setting, especially taking care of sick people without using proper PPE is an important risk factor. So we have to adhere to the basic standard infection prevention precautions. This is very crucial in reducing transmission to healthcare workers. The other important thing is transmission among from one nosocomial transmission can also occur from one patient to another patient who is admitted for some other reason. So these patients with Marburg has to be managed in a separate ward, and those with and without infection shouldn't be put in the same room ማለት ነው and any body fluid that come from these patients has to be I mean eradicated or go into the sewage system or incinerated in a separate pathway ማለት ነው. So this is very key. So any form of fluid contact with a sick is what we describe as contact with an alive patient or a dead patient ማለት ነው. Or any product or any inanimate object that is sick individuals come close to. So the most important pathogenesis wise, the most important cells that are affected are the cells of the reticuloendothelial system, especially the dendritic cells and the macrophages. So these are affected early, like from the skin or mucous membrane, where the virus gets into the body, it attaches to these cells and they affect them. So there is paralysis of these cells because these are the first responders are also these are the first responders and they will be dysfunctional. The other thing is there will be decreased function of these cells as well as dysregulated stimulation. So this dysregulated stimulation results in secretion of high amount of inflammatory markers or cytokines like TNF alpha, interleukin 6 and different dozens of other products of these inflammatory cells. So these TNF alpha interleukins and like that, they have multiple target organ damage. For example, they can cause endothelial damage. Widespread endothelial damage can resulting in coagulation, dysregulation, or disseminated intravascular coagulation or DIC ማለት ነው. The other thing is there is also preferential loss of T cells, lymphocytes, okay, especially the lymphocytes, their number and function will markedly reduce in patients with Marburg disease, okay? So one of the features of Marburg is lymphopenia. The lymphocyte count will be low ማለት ነው. So lymphopenic ይሆናሉ. And the other thing is, so as you know, እንግዲህ this macrophage like that in the reticular system involves the spleen, the liver as well as lymph nodes now. So there will be apoptosis, there will be intense inflammation and necrosis and apoptosis in lymph nodes in the liver, in the spleen, as well as in the adrenal. So there is loss of tissue in these end organs. Hence, it results in immunosuppression. So as you can see here, there is intense immune suppression. There is vascular injury resulting in disseminated intravascular coagulation. There is also increased permeability of the vasculature. As you can see here, there will be increased permeability. So there is leakage of plasma and other fluids into third spaces, and there is disseminated intravascular coagulation resulting in marked reduction in platelet count. There will be consumption coagulopathy, so the patients will bleed. So this is what we have learned from studies that were done long ago. The other thing is, as I have said previously, liver, spleen, renal are also affected, and liver dysfunction is prominent, and most of the patients will have increment in liver enzymes. And the other thing is liver function will also be deranged and the patient will have hemorrhagic tendency. So all this culminates in shock and multi-organ failure ማለት ነው. Additionally, the patients will also have like vomiting, diarrhea, non-bloody ማለት ነው. There could be non-bloody vomiting, non-bloody diarrhea, and loss of fluid and electrolytes will also result in shock ማለት ነው. So shock different mechanism, via different mechanism, shock will also occur. The other thing is, as you know, when there is a shock and immunosuppression, the gut will be leaky. That means the microbes that we do have, the billions of microbes that we do have in the gut will easily translocate into the bloodstream, and you will see a second phase of septic shock that arises from the bugs in the intestine. So when we come to the clinical picture, so the clinical picture, we can classify it into three forms. There is an early form characterized by generalized symptom phase, the next early organ dysfunction, and then finally the late organ dysfunction, or if the patient recovers, convalescent phase. So these are early organ, late organ, and the initial one is the generalized phase. So this one, the generalized phase, is basically more or less similar to any acute febrile illness like malaria and other uh, acute febrile illnesses, relapsing fever, or other tropical infectious diseases. So initially the patients will have fever. Fever is common, headache is common, fatigue, severe fatigue is the initial picture. Patients will have myalgia, malaise, chills, rigors, and subsequently, usually you will see this prodromal phase lasting for about 5 days. You will see development of GI symptoms like vomiting, diarrhea will start ensuing, and then the patient will develop bleeding tendencies like melena, hematemesis, petechiae, ecchymosis, mucosal hemorrhage, and visceral hemorrhage can also occur. So the patients will start bleeding more. So the patient will start bleeding. I'm audible, right? Can you see the slides?
Yes, you're audible, and the video is also clear, and we can see the slides.
Nice. So you will see bleeding ensuing. So bleeding will occur. Then subsequently, all these, like the disseminated intravascular coagulation, the coagulopathy, the organ dysfunction, the fluid loss, the electrolyte imbalance, subsequently will worsen, and the patient will start having or transitioning into an organ damage, where you will see air days like pulmonary edema will start occurring. The patient will have dyspnea, and subsequently the patient will have CNS manifestations, as well as shock, severe metabolic disturbance, and acute kidney injury, and the patient subsequently will succumb ማለት ነው. Okay, so in the first 5 days, you will see non-specific generalized signs. GI symptoms will start, and then sorry, bleeding will follow, and subsequently organ damage will start coming ማለት ነው. So you will see, usually in the study from Rwanda, most of the patients, usually within like 12, 13 days, those patients who died will die around this time, and those who recover also will start recovering after this time. So the disease usually doesn't go after 21 days, but after any viral infection, because of all the metabolic derangements, organ dysfunction, and like that, even the survivors might have lingering symptoms, okay? Lingering symptoms that might stay for a while, okay? So this is important. So as you can see here, viral detection occurs starting from early, and then it stays, as you can see here, it says virus detection. As you can see, the virus will be detected starting from the early generalized phase up to the final phase. Okay, so RT-PCR is an important parameter in the diagnostics. The other important thing is asymptomatic individuals, as I've said, doesn't transmit this virus. So as you can see, it is short. No? Previously in the previous slides that I have put, as you can see, most of the outbreaks are small in number. The maximum that you can see here is in 2004 and 5, where around 252 people were infected. One of the reasons is those patients usually will be sick, and the virus will result in the endpoint in very fast. It doesn't linger for a very long time in most patients. So this is one factor. And the other important factor is asymptomatic transmission is less, so you will see that. But the antigen, as you can see, will be detected a few days after, and IgM will take a while. IgM and IgG obviously will take a while to be detected, and there are no approved rapid tests for these disease, so we rely on RT-PCR. But subsequently, in the Rwandan case management last year, they have used IgM and IgG in addition to the RT-PCR. As you can see, lower in the clinical chemistry, in the part that says the laboratory part, thrombocytopenia is an important feature. Some degree of thrombocytopenia, like mild, moderate, or severe, could occur. So any degree of thrombocytopenia usually occurs in more than 80, close to 85% of the patients will have some sort of mild, moderate, or severe decrement in platelet count. As I have said previously, majority of the patients will have early lymphopenia, so the lymphocyte count will markedly will markedly be reduced, and it will basically paralyze the immune system. But some patients may have leukocytosis, but this is the most important, and the one that is more common is the lymphopenia. As you can see, SGOT and ST, LT and ST will also ራይዝ ማለት ነው። ኦኬ ኤስቲ ኤንድ ኤልቲ will rise. So as you can see, the AST is more and starts earlier than the ALT. So you will see more AST than ALT እዚህ ጋር as you can see from this graph ማለት ነው። ይሄኛው the darker እንትን ሃየር ቫሊዩ ነው የሚያሳየው ዛን ዘ ብሮከን ላይን ማለት ነው። ዚስ አር ኢምፖርታንት ፓራሜተርስ። ላብ ላይ ፕላተሌት እናያለን፣ ሊምፎሳይት ካውንት እናያለን። ያው ሊምፎሳይት ፐርሰንት ሳይሆን ቁጥሩን ዩዥዋሊ ኢት ኢዝ ጉድ ቱ ካልኩሌት ዘ አብሶሉት ነምበር ኦፍ ሊምፎሳይትስ as we do for neutrophils ማለት ነው። and you will also see sometime in some patients maybe some degree of not marked but some degree of leukocytosis can be seen, and liver enzymes are also elevated in more than 60% of the patients after admission. So these are some of the parameters that we see. This is basically what I have said previously. Generalized phase, early organ dysfunction, and late organ phases are the three clinical phase of this virus. So case definition አችንን እንግዲህ let's see our case definition. I guess it is visible here. So case definition like the first thing is suspected case. So Zika, here I want to stress something. So when we have an outbreak, the priority is not to miss a positive case. So the priority is not to miss a positive case. Okay, so we don't want to miss a sick person, an ill person. So because this is one, it is bad for the patient. The other thing, it also increases the risk of transmission to the community, to the public. So when we have a diagnostic criteria during outbreak for suspected case, it has to be sensitive, specific. It won't be specific, but it will be, we want it to be a sensitive test. So sometimes even these tests might not be specific. There might be false positive suspected cases, but it is good to have false positives than false negatives ማለት ነው። Okay, so that means in simple words, it is good to suspect more people, test them, than to suspect few cases, only very few cases, and pick a lot of cases and maybe miss few. Okay, because that is bad for transmission. So we want a sensitive test. So you should see it in this angle. So the other thing is, this is an outbreak that is transmitted via contact. So we do have clinical criteria, as well as exposure or epidemiologic criteria. So clinically, what we see first is the most important is temperature above 30 degrees Celsius. So someone with fever. The other thing here, it says end. So there has to be exposure. Okay, the exposure could be contact. Contact we have seen previously. Contact define organal previously. So contact with suspected, probable, or confirmed case while the case is alive or dead. If this is one criteria in addition to fever. So if you have these two, this is a suspect case. The other thing is without contact, if a person has recent travel or residence or contact with someone from an outbreak area in the past 3 weeks, this is again a suspected case. So the other thing is, so acute fever ነው እዚህ ጋር when we are talking about fever, a fever that occurs less than 2 weeks, in less than 2 weeks, and you should always test for other cause of malaria, other cause of fever like malaria, relapsing fever, and other things. And I also want to stress the presence of this doesn't necessarily mean that you have excluded Marburg, because sometimes they can occur. For example, in Jinka is a malaria area. Malaria is common in that area, so sometimes malaria and Marburg could also occur. In the Rwandan study, uh, there is overlap. Some of the patients with Marburg, around 6-7% of the patients there had concomitant malaria. Okay, so it is important to test other cause of infection as well. The other suspected case criteria is someone with more than 3 of the common flu-like symptoms and similar exposure history, like contact with a sick individual, suspected, probable, or confirmed, and or history of travel to outbreak areas, residence in outbreak areas, or someone with a contact from anybody who has traveled to outbreak areas in the past 2 weeks. So these are the clinical and demographic, epidemiologic criteria in the suspected case. Another thing is any unexplained fever, any unexplained days, especially in outbreak areas, is also considered a suspected case. And contact should also put someone at risk of I'm not saying travel, like it's contact, okay? So if you have contact, previously we have seen which contacts increase the risk. So anyone with a contact with suspected, probable, or proven case should be suspected, isolated, and looked for symptoms, and if symptomatic has to be tested. But for the others, for the first, the second, and the third, we have to go right away to the test. And for the last one, if there is symptom, we test. Otherwise, we follow for symptoms for 21 days. Probable case is when someone dies and when there is clear epidemiologic link to a confirmed case. But if days occur before laboratory sample was taken, we call this a probable case. A confirmed case is a case where you have suspected and then proved it via RT-PCR. Currently, the gold standard that we use is the RT-PCR test that they do at PHI. No case is when you have ruled out via RT-PCR. But remember, sometimes if you test early, for example, if someone comes with a symptom of 1 day or 2 days duration, the test might be falsely negative. So you might need to repeat when it is 72 hours or 3 days, starting from the onset of symptoms. So it is good to be aware that patient's test might be negative if you have tested it within the first 3 days of onset of the fever and other symptoms. Okay, so if it is negative and if it is indicated, you have to repeat, especially those patients in whom you have sent test within 1 or 2 days of onset of symptom. By symptom, I mean fever and other symptoms. Okay, so here is a very, very nice article. I really suggest every doctor in Ethiopia now, because it is an important issue for us as healthcare providers. I advise everyone to read this article. So as you can see, there are few Ethiopians who work there and who were involved in the management of the patients in the Rwandan outbreak, and they have also published this on the prestigious New England Journal of Medicine. Dr. Tsiyon Freo, Dr. Abebe Bekele, these are Ethiopian physicians. There is also one pulmonary care, pulmonary and critical care physician that studied his subspecialty at Black Line. So these are some of the people that are that have contact. That are Ethiopian origin. Okay. So in the first outbreak in Rwanda, because our guideline and other things are more or less similar to this one, and WHO in many forms, and this outbreak in Rwanda has given us a lot of insight about it. So they reported the first outbreak in September 27, and they contained it by December 20. So September, October, November, December, almost less than 4 months ማለት ነው። Usually when you declare end of an outbreak, it means that you don't have the disease in the past 42 days. So by December 20, when they say the outbreak is over, it means that in the previous 42 days, there were no any reported case. So the transmission, the case, the dates have stopped 42 days before December, the 20th of December. So they suspected more than 6,000 people, but they found 66 individuals, and the case fatality rate in this outbreak was 23%, 15 days among the 60 patients. So this outbreak is somehow unique in that it occurred in predominantly in a capital city. Most of the previous outbreak usually occur in remote jungle areas. So this is important to bear in mind as well. So this is the transmission. So initially in one hospital, they called it Hospital 1, there was a patient that they found who had contact with someone with a disease that was presumed to be HELP syndrome. So there was a woman, a pregnant woman, who was very critical and whom they considered HELP syndrome. She died, and her baby also died here. And another patient who was close to her also developed the disease and died. And some healthcare professionals also acquired the disease during this outbreak. And there was also a spread into another cluster. So most of the transmission to healthcare providers early occurred before it was identified that the disease was Marburg, okay? Because when the first woman was diagnosed, they assumed that it is HELP syndrome. So they did like CPR and other ICU care. That's why there was a transmission in that outbreak. But later, when they traced back, they traced it to her husband, who works in a mining in a cave, and his IgG was positive, and he reported that way earlier he was having AFI-like symptoms, and he recovered, and he was actually positive for IgG. As you know, IgG shows a remote infection. No? So from this phylogenetic study, they identified the source to be this guy works in a mine, and so he likely acquired it from bats and transmitted it to his wife, and his wife, while she was critical in the hospital, transmitted it to another patient and then to healthcare professionals. Subsequently, this happened. Okay, so it is after the first cluster of the cases that they were suspected. As you can see here, previously I said September 27 ነው አይደል ኮንፊርም የተደረገው the Marburg case, but before that there were cases. So most of the transmissions actually occur prior to it was identified. And when they went back, they found out that more likely her husband was symptomatic around August, early August. Then she developed it, and she had symptoms likely starting from late August, and subsequently she died. And this is actually a probable case, okay, because she died and was not, but they tested the husband and like that, and they confirmed, okay, this is how they did, okay, probable case ነው እዚህ ጋር as you can see the color coding lab confirmed ከዚህ በኋላ ነው የተደረገው she was the probable cause, and her husband was found to have IgG ማለት ነው. So this is important. Subsequently after the spike, cases dropped, and by the December 20, it was over. So for like 42 days, there were subsequently no cases, and it was declared that it is over. So let's see the characteristics of this outbreak. So the suspected are more than 6,000, the cases are 66. And most of the patients are actually young adults, as you can see, between the age of 20 to 50 years old ማለት ነው. So there were significant number of healthcare providers as well as non-healthcare providers, but mainly it occurred prior to the identification of the virus. After, there were also some cases, but the most occurred earlier, because when you suspect like Marburg or Ebola, you will be very careful in PPR. But before that, maybe sometimes we might even do CPR without gloves or without mask and like that. Okay, especially if you assume like the patient has HELP syndrome or something else. Okay, so this is very important. It shows how important it is to adhere to IPC guidelines as well. So this is important, and as you can see, yeah, uh, most of the patients, as I've said, are young people. Okay, majority of the patients are young people, and they reside in Kigali, the capital city. Here, you can see their viral load is high. Zigar less than 25 means the viral load is high. Zigar, it is not the viral load; it is the round that it will take for the PCR to detect the virus. So the lower this number, the higher the viral load ማለት ነው. So bear in mind when you read this article ማለት ነው. Okay, this is important because those patients, those with higher viral load has higher death rate ማለት ነው. The other thing is in this case series of 66 patients, you can see that around 84% of the patients has fever, but after admission, almost 95% of the patients have developed fever. Nausea, vomiting was present initially in 48% of the patients, but subsequently in 88. You can see headache initially in 61, then 82% of the patients have during the hospital stay, weakness in 69% at admission, and subsequently 92% developed disease. As you can see, other manifestations like abdominal pain, arthralgias, diarrhea, like as you can see, anorexia, diarrhea occur in 70, 74, 56% of the patients. And as you can see here, bloody diarrhea is low, other unexplained bleeding in 12%. So totally, the bleeding diathesis occur in less than a total of 40% of the patients. So maybe 50-60% of the patients with Marburg might not have actually bleeding. So remember that even though it is viral hemorrhagic fever, you may not have bleeding in some patients. This is important for clinicians. As you can see here, AST elevation was present in 34% of the patients during admission, but close to 70% after admission. So nearly one third will have elevated AST and ALT during admission, and subsequently you will see nearly two-thirds of them having elevated liver enzymes. The other thing is electrolyte imbalance is very important. Hyponatremia, as you can see, after admission occurred in 88% of the patients. Hypernatremia is also was also seen. Hyperkalemia, hypokalemia are very important. Dysglycemia with hypoglycemia, hyperglycemia can also occur. So you can see that electrolyte and glycemic imbalance is very, very common. Hyponatremia, 88% of these patients. And this electrolyte imbalance, they do have different mechanisms. And as you know, this could be fatal. Like it change in sodium level can be fatal. The same is true for other electrolytes. As you can see, leukopenia is more common than leukocytosis. So during admission, as you can see, leukopenia, WBC count below 4,000, especially lymphopenia, the lymphocyte count will be low in majority of the patients. 77% of the patients will have low WBC count, okay? Especially the lymphocyte count. Subsequently, around even 79% of the patients will have low level of WBC, okay? Serious infection with low WBC count. So this is it. But some patients may have leukocytosis. Okay, but leukopenia is a major feature. You might see anemia. As I have said previously, thrombocytopenia is very common, but the degree varies. Okay, usually mild to moderate, but some patients may have severe thrombocytopenia. Okay, so if you add mild, moderate, and severe cases of thrombocytopenia, you will see like close to maybe 80% of the patients, close to 80% of the patients will have thrombocytopenia. The other thing is, INR could be elevated as well ማለት ነው። Okay, so INR could be elevated as well. Subsequently, encephalopathy, respiratory failure also were seen, especially hypoxemia, encephalopathy occurred in like 73, 87% of patients, in majority of the patients who died compared to those who have recovered, and AKI was also seen in close to half of the patients who died, okay? But it was lower in those patients who recovered. 51 recovered and 15 died. So you can see AKI is more common in those who died. The same is true with hypoxemia. Hypoxemia, as you can see, ARDS develop ያደርጋሉ at the end of the day. ARDS and encephalopathy will be the features. For us, it is important to see also here that malaria was tested in most of the patients, and actually malaria was positive in 6 and 7% of the patients. So 7% of the patients who died had concomitant malaria. So in our setting, concomitant presence of malaria may even be a little higher, because that this one is a capital city in Bogale, and rural areas in Ethiopia like Inca do have a lot of malaria, so co-infection could be there. Bloodstream infection was also noted in nearly a third of the patients. I have said previously, because of the shock and the immune paralysis, there is transmission of the gut microbe into the bloodstream, and you will see sepsis arising from, or bloodstream infection arising from the gut. So gram negatives predominate ማለት ነው. So you have to target therapy for gram negative. Almost one third will have concomitant infection. Pneumonia can also occur subsequently ማለት ነው. So these are important. They have given dialysis, as well as they have intubated their patients. So two of their patients actually were extubated and survived, while the other 7 who were intubated have died from this experience, okay? And they have given like packed RBC, platelets, fresh frozen plasma, cryoprecipitate. So because these are important blood products that you need to replenish. But in the pathogenesis, we have seen how DIC occurs in these patients, okay? This is key. So this has shown us a very good insight. As you can see here, there is organ dysfunction like kidney injury, liver injury, electrolyte imbalance. So the mainstay of therapy here, as you can see, is supportive care. So you have to treat the fluid, the shock, the blood loss, the replenishing the blood products like platelets, if INR is high and bleeding, fresh frozen plasma, platelets, are packed RBC, and correcting electrolytes is very important in these patients. And when there is AKI dialysis, when there is ARDS intubation, and some supportive care as well for liver, like N-acetylcysteine they tried, but usually we know that it is important for liver injury caused by paracetamol, not by viral infections, but they anyways have used it, so you can try. So this is important. So as you can see, there is no FDA approved management for this, and there was no any clinical trial that shown benefit for any specific therapy. So supportive care is the mainstay of therapy. So because in addition to supportive care, as there was no any approved therapy for this, as a compassionate use, so when you don't have anything, you give medications as a compassionate agent or care, and they gave remdesivir, which is an a nucleoside analog and RNA polymerase inhibitor, as well as a monoclonal antibody that directs the GP, the glycoprotein on the envelope. Okay, so this they tried remdesivir as well as monoclonal antibody and N-acetylcysteine. They also gave, but the supportive care is more important, and maybe in our setting, in outbreak areas, this remdesivir might be available, but this one the monoclonal antibody might not be available, and it's going to be difficult also. It's going to be expensive. It needs cold chain, and actually, these both remdesivir and monoclonal antibodies, these are not approved for Marburg, but there are two monoclonal antibodies for Ebola. Like Ebola, there are two monoclonal antibodies. Ebola, there is also a vaccine. I think two vaccines that are approved for Ebola, but this one doesn't have any approved vaccine, no antiviral, no monoclonal antibody that was approved. But they used this as a compassionate because there is no other thing. And maybe in addition to the good ICU care, intensive care, it is probably the addition of these things that has resulted in lower mortality. As I've said, mortality was 15 people, 15 people survived and 51 people died in this series. So previously we have seen that contact is the most important mode of transmission. So the most important preventive strategy is IPC. Very important. Okay, so we have to be very, very cautious and adhere to the IPC principles. So if there is a suspect or a confirmed case, we have to wear the full PPE gear like we used to do during the COVID outbreak management. Okay. The other thing is maybe for healthcare providers who are exposed exposed and hasn't used any PPE, remdesivir can be used as a post-exposure prophylaxis for 3 days. But this is only when there is exposure without PPE in a healthcare setting. The other thing is they also tried a vaccine. This vaccine has never been tried and it was not approved. And so it was only on phase 1 because there was no any vaccine. They just tried this and has given for more than I think 8,000 or more patients took this vaccine. So they tried many novel agents as a compassionate use. These all things might have contributed to a better outcome in addition to the most important one, that is the supportive care. So IPC, strengthening IPC is very essential. Okay. So እንግዲህ we advise, maybe you have seen the national guideline. So hospitals should have incident commanders, public information officers, safety officers, liaison, operation, planning, logistic, and finance, and be prepared, especially in areas closer to the outbreak areas. Okay, even if the outbreak is not surrounding hospital, should have readiness, and then when there is a suspected case, they so that they can just act rapidly ማለት ነው. So this is important. So this is what I wanted to say. These are some important things. Maybe you can read those things, but clinically, these are the things. I think most of you are physicians. I don't know the composition of the attendees. If you have any question, this is also a new outbreak. Ethiopia has never had an outbreak of Marburg or Ebola, so we don't have a hands-on clinical practice, and most of the data is from this the studies, guidelines, and like that. So we have to share knowledge and update ourselves because it is an evolving science, and we have to keep tuned and share knowledge, articles, materials, reviews, and like that. Thank you so much. I started late. I think maybe I'll address a few questions and I'm done. Thank you so much.
Yeah, thank you very much, Doctor. It was an amazing presentation and an important one as well, and a time-sensitive one. So thank you very much for the amazing presentation, and to all the participants that were patient and that joined today's session. Thank you. So if you have any questions related to the topic, please write down your questions in the chat box. So there's one question by Nesri.
Mano Nesrat Tadessa. Okay, a very important question. So in suspected cases, transportation is very important. When when patients are transported, it has to be a special transportation. One, the ambulance has to be dedicated for these patients, suspected if it is suspected, as well as confirmed cases. The ambulance has to be dedicated for this purpose, and we shouldn't use it for another purpose because suspected patients, critical ill patients, usually when they are transported, they will be ill, right? So they will have various secretions, and transmission is easy. So ambulance personnel has to wear full PPE gear, and as much as possible, unnecessary transportations should not occur. And when they occur, it has to be under strict full PPE gear ማለት ነው transmission can occur. So when we transport suspected as well as confirmed cases, full PPE gear, dedicated ambulance are key. To pay the fees, this is admin based on your experience in infectious disease outbreak and health system. Do you think it will be contained to that area? የሚል ጥያቄ ተጠይቀዋል። Okay, doctor. As you have seen, the highest outbreak that was reported to date is few hundred, 252 or something like that in Angola. So cases like thousands and like that hasn't occurred to date. I don't think it's going to be any different in our case. So more likely from you remember the slide, yeah? I have shown you the outbreaks, and the maximum was in 250. So more likely, it's not going to spread to many areas by learning from history. But God knows what will happen tomorrow. But I think from the data at hand, it is more likely going to be contained to one area because aerosolized አይሆንም. It is easy, and asymptomatic people don't transmit it, and everything occurs very fast. So transmission to many people is less likely. COVID like someone before symptom can infect many people. Okay, and COVID patients even before onset of symptom, you can infect others. Yes, thank you. Thank you. Do we have tests? Yes. APHI, they do RT-PCR, but approved rapid test የለም. So do we have test? Yes, test አለ። ያው ማርበርግ ሪፖርት ያደርጋሉ። Thank you. How far is the current problem contained? So I think it is always important to follow the reports of EPHI and Ministry of Health. They are reporting on daily basis. Cases are being reported on daily basis. So it is good to follow those on daily basis and keep updated. የዛሬን አላየሁም፣ የትላንቱን አይቼው ነበር። የዛሬውን አላየሁም ሪፖርቱን። So follow EPHI and Ministry of Health. Is the vaccine available? The vaccine is not available here. And as I have said previously, the vaccine is not an approved vaccine. It was used under clinical trial, and we don't have the vaccine. So the efficacy and the side effects, gonna study ላይ ያለ vaccine ነው. It was mainly shown in primates and human ላይ phase 1 ላይ ያለ study ነው. There are no phase 3 studies. እሺ ፍሉድ እዚህ ጋር እንግዲህ ቴንክ ዩ ሶ ማች ዶክተር ጸጋሁን። ፍሉድ ማኔጅመንት ኢዝ ቬሪ ኢምፖርታንት። ሶ ዌን ዊ ሴይ ዛት ዜር ኢዝ fluid loss and resuscitation is key, we have to make sure that we are not overhydrating the patient and causing pulmonary edema. So always it is good to balance pulmonary edema versus hypotension. So you have to balance, and case by case decide የምናደርገው. So you have to balance this based on the case scenario. Otherwise you don't aggressively give like 3-4 liters. Otherwise the patient will have worsening of pulmonary edema. As I have said previously in the pathogenesis, the vasculature is leaky, so pulmonary edema, extravasation of blood and plasma products is high. So fluid has to be used cautiously, especially in those patients who are desaturating and having pulmonary rales and pulmonary edema symptoms. እሺ እንግዲህ እንትን ሰስፔክትድ ኬዝ ላይ we need epidemiologic criteria but unexplained bleeding other clinical picture ካለ you have to consider isolating and testing ማለት ነው። if አሁን ለምሳሌ አዲስ አበባ is common to see relapsing fever አይደል? relapsing fever is very common if you have and it resembles አይደል? the symptoms resemble እና so if you have symptoms like this one with no any explanation any especially if there is bleeding and like that you can consider testing in these patients ማለት ነው። okay this is important because one of the criteria in the suspected case is unexplained bleeding. The bleeding has to be unexplained. So if the patient has leukemia or any other thing, and if there is clear explanation, that is not a suspected case at all. If you have a clear explanation, but without clear explanation, it is important. The other thing is even patients with leukemia or whatever, if they have appropriate epidemiologic or exposure risk, still you have to consider in these patients, especially in epidemiology settings. Lab result RT-PCR, I'm not sure how fast they are delivering now. RT-PCR, yeah, the sensitivity and specificity is very high. RT-PCR now, the problem is going to be immunoglobulin ELISA no low RT-PCR is like you just see the RNA, right? So it is very high. You sequence the RNA, so they are very sensitive and specific tests for Marburg. But ELISA ነው ያው እንግዲህ ኢሹ የሚሆነው when we have ELISA like rapid tests for antigen and antibody that might be a problem but RT-PCR is very sensitive and specific. Okay, so outbreak if it spreads in one locality, various measures has to be taken to contain, to restrict, especially those people who are suspected and who do have clear contact. So Ebola and Marburg usually they resemble each other. So differentiating clinically is difficult. That's why they sequenced the virus initially before they reported, because clinically you cannot distinguish. Carrier stage after recovery, as I've said, most of the patients will not, but in some patients, like in semen, in tear, it might persist, but this is in those patients who have recovered. So sexual, they have to use barriers and other things after recovery. Thank you. These are the questions. I have a rest times later. I think let's wind up here.
Yes, yeah. So thank you very much, Doctor. On behalf of Blue Health Ethiopia and all our participants, thank you very much for taking the time to present on an important topic, and we hope to see you soon with other topics as well, Doctor. If you have any last remarks you want to add for the participants, let me give you the stage one more time.
Okay, thank you so much. So my recommendation is, there are I will edit the slides and I will share with Blue Health team, and tomorrow they will give you. So it is important that you guys read the article from Rwanda. It is very nice, and the Ministry of Health has also published the first draft of the guideline in a very, very short time. The team developed it very fast, and you have to also read the guideline. It has also very, very good information with evidences and the best available evidence. It is developed based on the available results. So read it, read the articles on New England. There are articles on Lancet, other review articles. So read the articles, read the guideline, the national guideline. PPE, improve PPE, use every opportunity to improve PPE diagnostics as well in your settings, especially if you guys are admin and like that, and stay safe, and God bless you all, and God bless our country.
Thank you very much, Doctor.